The Fashionable Personality Disorders in a Disordered Society by Alexander Fatik. The turn of the 21th century has been marked, for several decades, with an enormous prevalence of diagnoses of borderline personality disorder, BPD. This phenomenology has controversial origins, for which Lacanian psychotherapists believe that they have something to do with a political decision to diminish the prevalence of diagnoses of schizophrenias. Thus, according to the same view, the Diagnostic and Statistical Manual, DSM-IV, eliminated the latent schizophrenias and introduced cluster B personality disorders with the foundational BPD. At the turn of the centuries, BPD was the single most frequently given diagnosis worldwide. It was so prevalent that it gained notoriety as a kitchen sink diagnosis, which caught everything that could not be diagnosed as more traditional disorders. The general discourse on borderline vacillated between two different understandings of the very concept of borderline. One that purported to signify a grey area between neurosis and psychosis, where occasional psychotic episodes were seen as a sign of the person inhabiting a semi-psychotic diagnostic field. The other meaning was nothing to do with the semantic meaning. It suggested that borderline was characterized by certain temperamental and cognitive features that, in themselves, defined the disorder: impulsivity, splitting, the black and white picture of the world and others, fear of abandonment, imagined or real, etc. The very dissonance between the two conceptualizations of borderline allowed for the freedom of interpretation which made borderline a promised land for research. Consistent with difficulties in understanding and interpreting the very concept of borderline, cleavages also emerged in the therapeutic prognosis and assessment of suitability of borderline for various types of treatment. While most, psychotherapists considered borderline patients extremely difficult to deal with, partly because they tend to turn on the therapist after his or her initial idealization, the very dynamics of splitting, and blame them for all of their ills, others argued that borderline is almost naturally cured with age, and that as people get on with their lives, they tend to place their borderline traits increasingly under control. However, the discourse, until the second decade of the 21st century, remained focused in the individual features of borderline, not on the social conditions which give rise to this diagnosis. Rather than venturing into the culture to understand why we saw increasing numbers of apparently borderline individuals, and how their borderline dynamics is nourished by a fundamentally borderline society, once the obsession with borderline has reached its peak, it almost suddenly transformed into another obsession, with another cluster B personality disorder, the narcissistic personality disorder, NPD. Today, NPD and narcissism as a type of personality organization, whether formally diagnosed or not, command the large majority of psychotherapy podcasts and public discussions, and seem to steer clinical practice in a direction where it is now very difficult to disregard the cultural influences on narcissistic personal phenomenology. To me, these two obsessions are essentially the same. Apart from the fact that NPD and BPD share many of the same clinical criteria and dynamic features, they are both products of an era of social transformation which involved values rather than strictly clinical criteria as dominant tools to access the personality degeneration exhibited in those two disorders. Both disorders, as the dominating diagnosis overall on the psychiatric landscape in the West today, reflect a situation in mental health that philotherapy addresses by its own tools and through its own interpretative lenses. The primary value consideration for philotherapy in terms of both disorders is the issue of denial of responsibility, with all of the moral and structural consequences for clinical practice, for the future of the affected individuals, and for the society and social groups where these individuals live. It is the denial of responsibility, inherent in the idea that someone can be impulsive and insensitive to the needs of others, grandiose, self-centered, with a sense of overwhelming entitlement, yet that one might be so in ways which do not make them psychotic, and still qualify them for some kind of moral excuse or a sense of diminished responsibility that generates the most destructive social consequences. This gives additional relevance to Lacanian interpretations whereby the cluster B disorders, borderline, narcissistic, histrionic and antisocial disorder, are in fact derivatives of latent schizophrenia and ought to be treated as non-manifest psychoses. The problem is that, if the cluster B disorders, in particular BPD and NPD as by far the most prevalent, are treated as psychoses, then this involves a diminution of personal responsibility, but it also involves a certain setting apart of such persons from a range of social interactions. For example, if BPD and NPD were treated as psychoses, in child custody proceedings persons with such disorders would likely be considered unfit for full child custody. They would not be able to work in sensitive services such as the police, the military and in an array of medical fields, arguably, including psychiatry. This, then, would require formal assessment tools to be introduced for the special types of social transactions where BPD and NPD individuals would need to be filtered out, and as a result, large parts of the Western populations would be excluded from those types of transactions, leading to political and value system ramifications for the entire society. The reason, obviously, is that the prevalence of BPD and NPD is associated with the social transformation itself, where the values involved in BPD and NPD phenomenology are being gradually, and quickly, built into the very fabric of everyday society. The taking of ourselves seriously, which Lydia Amir so poignantly designates as the reason we are so often precluded from attaining what could be described as a good life, is closely associated with both the borderline and narcissistic features of our society and the concomitant inability to exercise, recognize and requires responsibility by any of the individuals who partake in such value systems where borderline and narcissistic phenomenology is prevalent. The inherent responsibility that is obscured by the narcissist culture where individual extravagance and self-absorption are seen as the sovereign rights of an individual and the prerogative of a tolerant society is clear when one starts in the Aristotelian way, from the individual, the particular, towards the general, namely by discussion how narcissism obscures responsibility on an individual, clinical level, and then by proceeding towards drawing more general conclusions of why the way in which we take ourselves so seriously is so problematic from a philotherapeutic point of view.